think I've seen most of you at my previous talks, so thanks for showing up. Today, I'm going to try and do a little bit of Slido just so that we can get a sense from each other what current practice patterns are. Like these are kind of cases that there's obviously no right answer to, and these were not exactly the same cases that were presented at the conference, but often similar cases were. And so today we're going to cover, there's about 6 things that I'm hoping to cover. To be completely transparent, there's not a whole lot new in the SVT and pregnancy realm. So if we run it short for time, I'll try and cut that. And I'll try and keep this talk to kind of 30 to 35 minutes and then leave some room for discussion and questions at the end. And just keeping in mind, there was a lot of content at this conference. There was a lot of potential stuff I could have talked about. So I tried to pick what I thought was more of like the latest kind of groundbreaking stuff that was at least new for me. And so hopefully you will find some of this beneficial. Obviously, I have no disclosures still. One of the first talks that happened at the conference was a discussion about when to use warfarin. And obviously, we have some very clear indications, such as like rheumatic mitral valve disease with atrial fibrillation, mitral stenosis, mechanical valves, if there's significant drug interactions that contraindicate DOAC. But then the topics that were raised at the conference were really about, what about the frail elderly? What about these people with BMI over 40? So we'll see if this Slido poll works. I'll give everyone about 30 seconds just for a simple case of an 85-year-old lady with non-valvular AFib who you're seeing for perioperative bridging. Her INR has been stable for many, many years. She's been on warfarin. Is this someone who, if it's within your scope, would you consider changing them to a DOAC in the post-operative setting, or would you just say, you know what, continue on your warfarin, you've been stable for many years?
I've entered my options. I don't know if it's showing up on your slide.
Yeah, they still show up once I click the slide.
I don't see the poll here, Gord.
Oh, really?
I don't see it on my end. I'm not sure if others can see it.
Like the answers or the whole poll? Let's have a look.
Do we know how many people voted? Is it 3?
It looks like, I think there's 3. Yeah.
Maybe just me. I don't know. I didn't see it.
Oh, sorry about that, Mina.
Yeah, no worries. But I would choose number 1 anyways. Continue our.
Okay, yeah, I think that's totally fair. A lot of this comes from Frail AF back in 2023, which a lot of us are familiar with. It was a multi-center, open-label, randomized controlled trial done in the Netherlands. They randomized over 1,300 frail older adults who had been stable on their warfarin for many, many years. In fact, the median time in therapeutic range for many of these patients was over 70% coming into this trial. The Dutch networks are known to have very good warfarin monitoring, and they do have very good time in therapeutic ranges. And they randomized these people to either switch them to a DOAC at the practitioner discretion for choice of agent or continue on warfarin. And then looked at the primary outcome of basically bleeding complications at 12 months. And Frail AF did show us that there seemed to be actually higher rates of bleeding events when switching to DOACs, as opposed to just continuing on with their current warfarin, which they had been stable on for many, many years, with no significant changes in the thromboembolic outcomes. I've always found it interesting. And then as we can see with the Kaplan-Meier curves, he's just continued to separate over time. And so I've always found it interesting. And I remember reading the Frail AF study thinking, wow, there were 332 patients on rivaroxaban, though, and these are in the frail elderly population, which a lot of the atrial fibrillation guidelines say, we should really try to pick other DOACs for concerns of increased bleeding risk. And you can see that in the subgroup analyses, patients on endoxaban, maybe they're rates of bleeding were lower compared to those with rivaroxaban, but even apixaban in the middle, seems like in the subgroup analysis could be on the higher end of bleeding. So I remember reading this study thinking, it's interesting that so many patients were put on rivaroxaban. But hey, perhaps we should just look at continuing warfarin for people who have been stable for many, many years. Combine AF was discussed at the conference. So this is a large meta-analysis where they took individual patient-level data from the large 4 DOAC versus warfarin trials for atrial fibrillation. So it was RELY, ROCKET AF, Aristotle, and Engage AF, TIMI 48, which was edoxaban versus warfarin. And then specifically answering this question about the frail elderly, this was a sub-study looking at these 5,900 patients amongst the 70,000 total patients in the Combine AF database. And these were the frail elderly patients that they isolated out to then say, can we get a second look at this group who have been stable on warfarin? And then what happens when we randomize them to DOAC versus VKA in these previous trials? These patients were followed for a little bit longer on average, 26 months as opposed to 12 months with frail AF. And the baseline characteristics look overall a bit similar. Perhaps a lower risk population was actually seen in frail AF. This population, only 15% had paroxysmal, so we're presuming a fairly reasonable burden of atrial fibrillation. There was, again, a 68% time in therapeutic range for the patients coming in on warfarin. The average age was around 80, CHA2DS2-VASc scores of 5, and various DOACs used in these trials. And sure enough, at first glance, you start to wonder, there really does not seem to be a major difference between stroke systemic embolism, not surprising, but then also major bleeding, hazard ratio of 1.06 comparing DOAC to warfarin. And major GI bleeding, we see actually looks to be higher on DOACs. So the trend seems to be fitting with frail AF so far. Not surprisingly, as we've seen from previous trials, higher rates of intracranial hemorrhage on warfarin, but overall all-cause mortality actually not that different. Until you look at this very interesting part of the trial where they separated these patients out into various DOACs. So when you look at just the apixaban and edoxaban arm and you remove rivaroxaban altogether, there does not seem to be a significant trend towards higher rates of bleeding. In fact, there's an overall reduction in major and clinically relevant non-major bleeding, and certainly lower rates of intracranial hemorrhage with comparable stroke protection like we've seen in all the previous studies. So it does seem to me like when you add in rivaroxaban, which they also tried to do here, they looked at an identical DOAC mix to what was studied in frail AF. And again, they saw with that combination of DOACs, specifically like a much larger proportion of rivaroxaban, there was this higher rates of bleeding seen again in this same cohort. Again, there's a few differences between the patient population seen here in frail AF. Frail AF did have slightly higher GFRs. They had lower CHA2DS2-VASc scores, and they had less frequent history of bleeding coming into the study. So it may explain some of the results, but also to me, it sure seems like edoxaban and apixaban would be safer options than rivaroxaban. And essentially, the authors of this Combine AF sub-study conclude that switching to a DOAC is a reasonable strategy for frail elderly warfarin-experienced patients, particularly to reduce risk of stroke, systemic embolism, and the most severe bleeding events, which are obviously intracranial and fatal bleeding, which is obviously clinically more relevant than some of the GI bleeding that we see. So that's a little bit about kind of the comments around the frail population. And then just very, very quickly, I'm just going to talk about these patients who have a BMI over 40. So this was another sub-analysis of the Combine AF population. And they looked at the outcomes of patients across different BMIs. And so the results of this sub-analysis, they do seem to confirm the so-called obesity paradox, whereby at higher BMIs, we actually start to see lower rates of stroke and systemic embolism generally. Overall, lower rates of bleeding seen on the DOACs, especially at the lower BMIs. But then it seems that at BMIs over 40, we start to see a rise in mortality risk, despite an overall protective effect of warfarin or of DOACs across all BMIs. It does seem that when you look at the group whose BMI is over 40, we see higher rates of cardiovascular death with a hazard ratio of around 1.55. And specifically, it seems to be stemming from significantly higher rates of heart failure related deaths. So these are not deaths related to stroke or systemic embolism outcomes. And so the people who presented some of this data at the conference were speculating, there are other vitamin K dependent factors, like there's a factor called GAS6, which can be elevated in patients at very high BMIs and does have implications for things like heart failure. GAS6 has a role in inflammation and hemostasis, and there seems to be some speculation that perhaps there's some other mechanism at play whereby warfarin is a little bit protective for these patients at BMIs over 40 compared to DOAC when it comes to cardiovascular death. Okay, and then we'll move on to quickly talking about some of the data that was discussed with regards to RENOVE, but specifically the RENOVE subgroups, which are well tucked away in the supplementary data, I will say. So that brings us to the next slide of pool. So you have a 65-year-old male with a history of unprovoked PE. His weight's 108 kilograms, his height's 5'7", his BMI's 37. He's finished 6 months of anticoagulation. Sorry, did I say 6 months? There's no concerns for CTEPH. Would you dose reduce this person? Okay, so 2 people said yes, 1 person said no, and somebody else undecided. So I'm not going to, I think we're all pretty familiar with the RENOVE trial here, so I'm not going to rehash too much of the original study for the sake of time, but just quickly we'll recall that RENOVE trial was an open label study randomizing VTE patients, specifically PE, proximal DVTs, to either reduce dose DOAC or full dose DOAC using either apixaban or rivaroxaban. And these were patients who had already completed their initial 6 to 24 months of full dose anticoagulation, and they were patients in whom there was an indication for ongoing anticoagulation. And then they looked at the outcomes of of symptomatic recurrent VTE as their primary outcome. And then their secondary outcomes were primarily bleeding related outcomes. And they had a composite outcome as well. And they enrolled over 2,700 patients with just over 1,300 in each arm. They followed them for a median duration of around 37 months. And although they did not reach non-inferiority for dose reduction, the recurrence rates in both these groups were very low, and there was a large reduction in bleeding outcomes. The composite outcome of recurrent VT and bleeding was lower in their dose reduction group, with a 5-year cumulative incidence of around 11.8% versus 16.5% in the full dose group. And so the authors conclude from this trial that reduced dose strategy may be a very reasonable option in patients where bleeding is a major concern. And I will say for a lot of our patients, especially over the long term, bleeding becomes a concern. It is very interesting when you start flipping through, like I had to dig way into the supplementary appendix. It's like a 100+ page document, and they really tuck this in there. But it is interesting to look through some of these subgroups when it comes to the primary outcome. This is one of the things that was discussed in one of the debates early on, which is patients who have BMIs over 30 who were dose reduced. They did seem to have higher rates of recurrence. Obviously, we need to keep in mind these are subgroup analyses. So these are exploratory. These are hypothesis generating. We should not be relying on this with confidence for clinical decision making, but it does raised some interesting questions, I'll say. Females also maybe higher rates of recurrent VTE when dose reduced. And then when we look at some of the bleeding outcomes, maybe not surprisingly, females who were left on full dose had higher rates of bleeding, and patients over the age of 65 had higher rates of bleeding. So this did come up as a concept in one of the debates early on, which was, for these patients who are otherwise low risk for bleeding, who are younger in years, but their BMI is well over 30, should we be looking at dose reduction or not? Another interesting trial that was presented was ARIVA, which was looking at a combination of antithrombotics after venous stents, which I think is an ongoing interesting dilemma. So this Slido case is a 45-year-old lady with chronic left iliac obstruction, thought secondary to May-Turner anatomy. She had a history of DVT that's been well treated, and then she undergoes venous stenting for post-thrombotic syndrome. So following her stenting, would you do DOAC plus antiplatelet, single antiplatelet, or dual antiplatelet for her? And we'll say initially for the first 6 months or so. Okay, so most of us would do DOAC. Some would do DOAC plus antiplatelet, others would do single antiplatelet. And I think that this is a lot of what drives a lot of this, is that there's really not a lot of formal guidance for antithrombotics following venous stenting. And there have been other studies showing that there's a wide range in practice amongst providers who are looking after these patients. And so this brings us to ARIVA. So this was a trial that was published in 2025 in AHA. It was a multi-center randomized open label clinical trial, and they took patients between the age of 18 to 75. I think the median age ended up being around 43. And they had to have confirmed post-thrombotic syndrome secondary to stenosis or occlusion of the iliac common femoral, and who underwent successful venous stent intervention. And they randomized them to aspirin plus Riva-20 versus Riva-20 alone for prevention of stent thrombosis. They were really only looking at outcomes over the first 6 months, primarily being stent patency, but also looked at quality of life and bleeding outcomes. And so they ended up recruiting 169 patients, randomizing 162 patients. There were about 80 in each arm. And over the 6 months, the rates of stent thrombosis were very similar between the two groups, with no significant outcome. But clinically relevant non-major bleeding was as high as over 8% in the dual therapy arm versus 2.4% for rivaroxaban alone, which essentially leaves us with, there's probably not a role for an additional antiplatelet beyond DOAC for the first 6 months of venous stenting, is what this would suggest. I will say there was a lot of hesitancy at the conference to commit to any other answer with regards to long-term antiplatelet. And I think a lot of this just stems from the fact we don't have a lot of data with regards to what to do in the long term for these patients. And that, I will say that also adds to a lot of other literature we've seen recently, like the aquatic trial, showing that the addition of antiplatelet to DOAC for many patients does significantly increase bleeding risk. And then something that hits a little bit closer to home. So the COBRA trial, they presented the preliminary data. I have limited myself here in presenting just what has already been published. So there was some of this preliminary data was already presented at ISTH online in June of 2025. So there is like a small published preliminary thing there. But COBRA is a prospective, randomized, open label, blinded endpoint trial looking at patients with acute symptomatic thrombosis, proximal DVTs, or segmental or higher PEs. And these patients must have received less than 72 hours of anticoagulation at the time of enrollment. And the treatment arms for this study were rivaroxaban at our usual doses versus apixaban at our usual doses for VTE. And their primary outcome was clinically relevant bleeding at 90 days. So this is primarily looking at the first 3 months of treatment, apixaban versus rivaroxaban in terms of bleeding. And I was shocked at these numbers, actually. So 7.2% total bleeding outcomes seen in the rivaroxaban arm compared to 3.3% in the apixaban arm. So obviously statistically significant with no difference in recurrent VTE or mortality that was seen. And it certainly does seem that this was stemming from both major and clinically relevant non-major bleeding separately as well. A lot of us were speculating that, rivaroxaban, they unfortunately did that like 21-day lead-in period with the BID dosing. And we know that rivaroxaban is already associated with potentially higher rates of, GI and other forms of bleeding. And so perhaps this is what is driving a lot of this outcome. We'll quickly talk about, so I had previously given a rounds talk on anticoagulation and end-stage renal disease. And so we're not going to recap a lot of what had already been discussed. But there was one thing I did not talk about then, which came up again in the conference as a small part of one of the nephrologists' talk. And I thought I would just discuss that quickly. And this, the niche question, but I've seen it asked a few times, is that what do you do with these dialysis patients who are on apixaban going for surgery? So let's say this is a dialysis patient who's on apix 2.5 twice a day, and vascular surgery asks you how long should we hold the DOAC for their AV fistula. You can interpret the vascular surgery component however you'd like. They are quite confident with their blood thinners in the OR. So. Okay, let's see what everyone said. Okay, last host day -5. Okay, so everyone's saying last host day -5. Let's see. So this was a paper that I did present in the talk I had given a few months ago on anticoagulation dialysis patients. And this was one of the pharmacokinetic studies looking at apixaban in dialysis patients. And these were patients who had received either 2.5 or 5 milligrams for several days in a row to reach steady state levels. And then they measured these levels in the days following discontinuation during this washout period. And it was surprising to me. So this is looking at the 5 milligram BID dosing, which admittedly we don't see a lot used in dialysis, but I have still seen it occasionally used for very off-label purposes. But look at the dialysis group, after 5 days of discontinuation, still 16% of that group after 5 full days of holding the anticoagulant had apixaban levels above the cutoff of 50. And with only, let's say we gave the usual advice, which is hold 48 hours for normal non-dialysis patients, it would be actually close to 60% of those patients who would have apixaban levels of over 50 if you're using 5 BID. But admittedly, we don't often use 5 BID. So what about the 2.5 BID? And this is again using a cutoff of 50. So they had also shown us data using a cutoff of 30. And so obviously if we use a cutoff of 30, these rates are a little bit higher as well. But even after 5 full days of holding the 2.5 BID, just under 6% of cutoffs above 50. And so clinically, how does this play out? I really don't know, to be honest. I think if well, I'll leave it for discussion. We'll say that. But certainly, if we're only holding for 3 days, 15% of these patients having a pick span levels over 50, and then certainly, only holding for 2 days, we're close to 30% of those patients having pick span levels of over 50. So I'll be curious to hear what you guys might do or not do differently, knowing that data. I did also, there's one other thing that one of the authors who was presenting this paper had mentioned, which was he kept referring to them using low molecular weight heparin on dialysis. And I wondered if they were using low molecular weight heparin in their dialysis circuits, which we don't use in BC. My understanding is we use unfractionated heparin. But if they were, I know in other countries, other centers will use low molecular weight heparins. And if they were using that, they were using an anti-10A technique to measure these DOAC levels, which would be very prone to interference by any other heparin product as well. So part of me wondered a little bit if there was some heparin that was not being accounted for on their dialysis runs, could that be kind of, so to speak, artificially raising these supposed DOAC levels? But we do also kind of see this trend where, when you go back to the 5 BID mark, it certainly seems to just kind of be creeping up as your GFR is lower and lower, and then subsequently onto dialysis. So I'm not so confident. And then the last thing I think we have a few minutes to talk about was SVT in pregnancy. And so this was a case that was presented. So a 29-year-old G1 who's currently 32 weeks pregnant. She has a palpable cord, subsequently 4-centimeter clot in the greater saphenous vein, just over 3 centimeters from the junction. And then would you do prof, intermediate, or full dosing for her? Okay, yeah, lots of people would do prof. So this was Dr. Camille Simard, who was she's from McGill, and she had given this talk on SVT and pregnancy. And so she had quoted for the incident rates seen in pregnancy, a study that was looking at a Danish birth registry, and they found an incident rate of around 0.3 per 1,000 person years in the antepartum setting for VTE, and then 1.6 per 1,000 person years in the postpartum setting. These are the 12 weeks postpartum. I was a little bit surprised those numbers weren't a bit higher, but I guess that's certainly above the average population. And then of the 211 women who developed superficial vein thrombosis, 13 of them were subsequently diagnosed with VTE, and the median time from SVT to VTE diagnosis was 45 days. And so looking through the guidelines around this, there's not a lot. The SOGC in 2014, everyone seems to agree compression ultrasound should be done for these patients with suspected SVT to make sure that there's not a DVT and to assess for proximity to the deep system. But we really don't have a lot of great data around who is at risk for progression to PE and DVT in pregnancy specifically. So I was actually a little surprised that the SOGC in 2014 gave such a wide range of treatment duration. They said low molecular heparin for 1 to 6 weeks. And then favoring treatment if there's bilateral involvement, if they're symptomatic, or if it's less than 5 centimeters from the deep system. And they essentially said prof or intermediate dose low molecular weight heparin would be reasonable here. And then for the distal, shorter clots, conservative treatment could be considered with a repeat ultrasound in 1 week. The ASH 2018 guidelines are a little less concrete than that, and they say generally prefer treatment, low molecular weight heparin is generally preferred over no anticoagulation. And then obviously we know that for non-pregnant patients, if there's a confirmed DVT, obviously we treat with full dose anticoagulation. If we're within 3 centimeters of the deep system, then we'll opt on the side of usually therapeutic anticoagulation. And then if we're more than 3 centimeters from the deep system and more than 5 centimeters in length, then we'll consider doing some prof dose for 45 days. And then if it's small and even more distal, we can often try conservative things. And so her practice, the speaker had again recommended compression ultrasound for diagnosis to exclude DVT in these patients. Obviously, there was the usual very shared decision-making amongst these pregnant patients who are also at risk for bleeding and who we need to make sure have delivery in their modality, in the modality of their choosing. But that their practice was that they generally treat these with low molecular weight heparin, usually for a full 6 weeks, and they seem to be using a lot of this 50% weight-based dosing, followed by prophylaxis thereafter in the remaining of the current pregnancy. And the presenter is also involved in like an ongoing data collection for a Canadian case series of these patients. So that will be interesting to see what the Canadian experience has been when we see that data collected and presented.